section. So next we have Dr. Tom Land, who's the Director of Health Information Policy and Informatics, a new office at the Department of Public Health. Dr. Land has been really renowned nationally for his early research centered around the impact of tobacco use and tobacco policies on health outcomes. This work has included documenting reductions in heart attack deaths related to our Massachusetts smoke-free workplace law. Dr. Land leads a team that has developed a comprehensive evaluation of clinical and community initiatives that are person-focused. His work includes managing the development of a generalized bi-directional e-referral system that links clinical and community settings, as well as the development of an extensive surveillance system to track and link telephone survey and field data through geocodes. Dr. Land.
Thank you, Commissioner. Thank you, Ann, Paul. Can you hear me? Okay. It seems like for the past 30 years, every project I've ever worked on has felt like a patchwork of all sorts of stuff that gets put in front of you. Some of them have worked out well, some of them have looked like patchworks at the end, and you can blame the seamstress for that. But my presentation will be an attempt to show you some of the patches and an attempt to try to stitch them together in a description of what we're trying to do with the Prevention and Wellness Trust. So I'm going to cover the bi-directional electronic referral system, some health information systems that we're working on in conjunction with the Metropolitan Area Planning Council, as well as the Prevention and Wellness Trust, and I'll give a shout out to the AAA, but also to some other projects that are happening. So the bi-directional e-referral system, it's actually an open source system. It's open source, vendor neutral, bi-directional e-referral to promote community clinical linkages, which sounds really impressive, but I think the most impressive part of it is that's probably the only sentence you'll hear in your entire life that has 5 hyphens in it. So this is part of the CMS State Innovation Model Award that Ann manages, and it's a relatively small part of it, roughly 10% of the total budget. And what we're trying to do is build a system that promotes the conversation between clinical systems and all of the community-based organizations that are out there. So we chose those that we thought we would have the most impact with. And again, this is about the AAA because we're trying to improve patient experience by connecting them to community resources, to improve health outcomes, and to save money. So this is, the first thing we had to do was we actually had to define what a community referral was. So a lot of people would come up with somewhat different ideas. So a bi-directional referral to us is something that actually was the complete transit all the way from the provider's office through the community services that are provided to the individual, with a feedback report telling that provider what happened on the outside, and then that information gets deposited back into the patient's medical record for 2 purposes. One is that the provider needs to know what happened, and that it allows us to evaluate the effectiveness of these services in terms of the clinical outcomes of the patient. This is the schematic that we use to describe what that bi-directional referral system means. And on the left-hand side is the vendor neutral part of it. So essentially what we're saying is we're building something that it doesn't matter what type of electronic health record system the provider is using, that whether it's NextGen or Epic or eClinicalWorks or Allscripts, that this system will allow the conversation between the provider and the community-based organization, regardless of what's on the left-hand side of that equation. And on the right-hand side of the equation are all the community-based organizations. So that's the linkage part of it. That's the second hyphen. But what happens in the middle is this translator system, which we're trying to say is the way in which you can get as many people in the conversation as possible. It's a universal translator model. Nothing's ever completely universal, but we believe that by permitting as many types of conversations as possible that are defined by the provider and the community-based organization, we don't define them for them, that we can increase the likelihood that people talk to each other. So these are the groups that we're working with, the Smokers Quit Line, the Massachusetts Tobacco Cessation Helpline, the YMCA's of Massachusetts, Visiting Nurses Associations, and Councils on Aging. And you've got a list of the different health outcomes that we are, or behaviors that we are trying to impact with this program. So, actually, I have to look ahead to see where I am. So again, this is the aspects of this that we really want to emphasize are that this is an open source software, that it has a node on the Mass Highway. So again, it's available to all providers. It's not just available to the set that we're working with in our State Innovation Model Award. We have intensive TA for the CHCs that are working with us, but we're developing a toolkit for all of the different providers around the state that will allow them to ultimately connect to this through either the Mass Highway or directly through the Universal Translator. So this is a tool that we think that people can use, and what we'd like to do is the open source system should be available around June of next year, and we'll begin rolling out the toolkits after that so people can begin to utilize them. Health information is another part of what we try to promote at the Department of Public Health, and this is going to be an ultra quick tour of what we've been working on with the Metropolitan Area Planning Council. We developed a website which looks rather hard to see, but this is called ourhealthymass.org, and Our Healthy Mass is essentially public health information in a way that allows the public to use the information. It's not predefined by the Department of Public Health or some other entity. It's a very flexible system that it is, we provide some information like data stories about different communities, but what we're really trying to do is get people to actively use the information. So they can put any combination of information together with any other combination of information and look at that in terms of where their community or their region lies with respect to the rest of the state. So Our Healthy Mass is, again, something that is a public-facing website. It uses the Weave visualization platform. It's very graphic. It sometimes is intimidating to some people the first time they use it, but it's also designed for both beginners and advanced users. There are virtually limitless combinations of information that can be presented by the purveyors of this or by the users of it. And we're currently exploring, the Metropolitan Area Planning Council, in conjunction with the Department of Public Health, have applied through the Knight Ridder Foundation to develop this into an automated health impact assessment tool for people to use. So how does this all come together in the Prevention and Wellness Trust? The Prevention and Wellness Trust is a combination of trying to utilize the information and use that information to define a health system or a program that is rolled out in communities or regional areas that, again, achieves the triple aim. It improves patient experiences, it reduces health chronic outcomes for patients, and saves money. So, again, it's a $57 million fund over 4 years. We're into about the 4th or 5th month of this, so we've got roughly 3.5 years left. There's no requirement for spending money annually, so this is, again, flexibility that the Department of Public Health generally doesn't have when we work off of a fiscal year. At least 75% of the money has to go to grantees. No more than 10% will go to worksite wellness, and no more than 50% for administration by the Department of Public Health. So from an evaluator's point of view, the fact that the outcome measures are actually written into the law has really given a different perspective on this program than you often see. And these outcome measures are reducing the prevalence of preventable health conditions, which has been mentioned several times, reducing healthcare costs or the growth in healthcare costs. And we also need to look at the beneficiaries of any cost reductions or savings. So if there's a particular subgroup that benefits more than another, this is part of what we have to talk about in our final reports. There's a worksite wellness part of this, and we have to look at employee health, productivity, recidivism, and through our workplace wellness initiatives. And finally, all of this has to be done in 4 years. So this is again, all of these daunting elements, but those elements became the rubrics that we used in order to look at how we would plan something like this. So We started with a set of guiding principles. We said we wanted to use evidence-based interventions. We wanted to target areas with high incidence because, again, we thought if you target areas with high incidence, you're more likely to achieve your goals. We look at risk factors and diseases that lead to significant cost savings because not everything does. We promote strong linkages between clinical and community, and we look to maximize return on investment while we are also producing what we hope are sustainable changes in these communities. So we looked at a lot of data. We looked at things like inpatient hospitalization charges for diabetes. We actually looked at 13 different health conditions that had some evidence for showing improvements in either health conditions or costs. So this is a graph for diabetes. It's going up. That's the wrong way. This is a graph of how it looks like. We looked at regional differences within the states. So this is the prevalence of hypertension. Not every community has as high a rate of hypertension as other states do. We also looked at things like gateway communities. How do these different things align with each other? So our gateway communities have higher prevalence of different health conditions than others. And we put all of this together into a plan where we looked at priority, optional, and other conditions. We chose the 4 priority conditions because they had the highest likelihood of showing healthcare cost savings and improvements in health over a 4-year period. We looked at the types of interventions that were available, where there was evidence to demonstrate effectiveness for these, and the tobacco use, pediatric asthma, hypertension, and falls prevention among older adults were those that showed the highest likelihood, in our opinion. We've had a lot of, the Prevention and Wellness Advisory Board reviewed this. This was something where we got a lot of input from a lot of public health departments, from within our own department, from universities, in order to look at this and determine that these were the most likely candidates. The optional ones are ones that have less evidence to show short-term healthcare cost savings, but there's definitely evidence that they improve health and show healthcare cost savings. And finally, there are those that where there may be emerging evidence, and we wanted to have communities have an opportunity to propose ideas that would be evidence-informed as well as evidence-based. All of these can be done in conjunction with on vulnerable populations or to emphasize mental health or behavioral health issues across all of these conditions, and the applications are coming to us around November 1st at noon, and at that point we begin the review process. Another really key aspect of this is that we didn't want to create a bunch of mini silos in communities. What we wanted to do was we wanted to require communities to work in all 3 domains: clinical, community, and a clinical community linkage. So every health condition for which an intervention is proposed in a community has to have something in the community, clinical, and the linkage area. So they can't just propose something that's clinical or something that's community. They have to propose all 3. So again, what we're trying to do here is applying all that knowledge. We've used the data that we have developed over the last decade in public health to look at the impact on the public for healthcare costs. And we're trying to align this with other Department of Public Health programs so that we have efficiencies like community transformation, mass in motion, and the CMS State Innovations Awards. And the applications, as I said, are due November 1st. There were half a dozen other things that I could have included in here, looking at the APCD, ways that the department can use meaningful use to promote public health outcomes. I just wanted to put this one up because it aligns very closely with the Affordable Care Act and the community health needs assessment requirements that are required for within the IRS regulations. And again, this is something where hospitals and communities can work together. It's a requirement. It's not something that, again, is done in a vacuum. This requires community involvement. So again, I think this promotes the conversation across community and clinical settings, so that we have the highest likelihood of having a change in the system, and in this case, the system being the conversations that take place in each of these communities. Thank you.